So, good evening, one and all. So, this is the 13th series of this molecular tumor board, and it has been going on great till now. And for today, we have 5 cases for discussion. And the first case is by Dr. Nadeem Ahmed. Over to you, Dr. Nadeem.
Hello. Good afternoon, everyone. I'm Dr. Mohammed Nadeem Ahmed. I work at Maitri Hospital and Renova Hospitals as a consultant medical oncologist in Hyderabad. So this is a case of 78-year-old female. She was initially evaluated for breathlessness and was detected to have pleural effusion. Then on further evaluation was found to have axillary lymph nodes. PET scan was done which showed bilateral axillary lymph node, right more than left, with right moderate pleural effusion, some pleural nodule, mediastinal nodes, and consolidatory patches, and some inflammatory retroperitoneal nodules also. Biopsy was done from both pleura and the axilla. Biopsy from pleura came out as inflammatory, but biopsy from axillary node came initially as adenocarcinoma, which was TTF1 positive, pulmonary adenocarcinoma. So she's from the time of diagnosis of this pleural effusion, she's wheelchair bound. She's able to walk with support till washroom, but breathlessness on little movement also. So we waited till her molecular analysis report came. We sent a 50 gene panel from at core, which I have shared, which came out in 4 or 5 days. This report as being shared on the with you guys on the screen is suggestive of EGFR P L858R positive and also EML ALK positive. So now this report came a couple of days back. Till then, we couldn't give her any chemo because of her age and her performance status. Otherwise, she's not having much other comorbidities. Her EF is 50%, hypertension under control, and GCS is 15, CARC score is 50 with the mono chemotherapy. Chemo, anyways, is out of question for her. So, with this report, I have started her 2 days back on Electinib 300 mg BD. I wanted to discuss this case because of 2 mutations.
Thank you. Thank you, Nadeem. Okay. So, any thoughts from others? Otherwise, I can share my thoughts to start with. So, probably before somebody starts, I will give my thoughts. So, we'll go to others. So, one is you see the tumor percentage, tumor fraction is almost 30%. So, if you see the EGFR as far as the WAF is concerned, is 5%. I think you can just go there.
Yes.
Just go to the WAF. Okay. Yeah. Go to the next page. Yeah, so I think 28% is the WAF of fusion. So looks like that is the driver. And whatever the EGFR, the mutation, what we are seeing, probably it's a subclone because it's only 5%. So I agree with your plan I don't think we should, because of the toxicity, PS is 375-year-old. Combining EGFR and ALK, I don't think the patient will tox, and there's not much of data. So driver mutation for me, I think it's a fusion EML ALK, and I think probably I would have gone for a complete panel. That would have helped. I think it's a short panel, what a hotspot mutation, what you have checked. Probably a broader panel will help to see other co-mutations to characterize the prognosis. So this is a hotspot panel that has been done. But whatever the panel that we have, I think the predominant driver is the fusion and the subclone is the EGFR. And I agree with that. Probably I would have gone for lorlatinib straight, but alectinib also is a good option. This is what is my thought. Let's hear from others.
So one thing I want to add. I discussed with Dr. Aditi, who reported this. So she told that yes, there are only 5% WAF for EGFR. So she, out of her own interest, she did a PCR EGFR also, which came out as positive. PCR. Then one more thing is she tried to run an ALK IHC, but she couldn't do. And she says that ALK 28 reads only were there. Now, how to interpret this?
Okay. I think Arun Kumar is here. I think Arun Kumar, other molecular, they can take a call.
Sure. Thank you, Dr. Nadeem, for this case. And thanks, Dr. Arun, for your comments. So see, what we see here as 28 are, just as just now Dr. Nadeem said, they are not WAF, they are number of reads. So how many reads were identified which had both EML4 and ALK together in the NGS experiment is what it is reported. So there is one cannot say there is a cutoff. One cannot say if this is less or more. Even if something is reported, that means it has been identified. So bottom line is you cannot compare the variant allele fraction of EGFR, which is 5.2%, with 28 reads of EML4 ALK. So they could be, in terms of VAF, they could be equal, or one may be more or less. So with this statistic, we cannot compare. There are labs which also report fusion or the VAF of fusions. If that is there, maybe you can give a comparison. But based on this, one cannot say which is which is more higher, larger clone, and which is a smaller clone. This is point number one. Point number two. Already you mentioned this is a very poor performance status patient. If I don't have those clinical characteristics in mind, based on the multiple studies and the retrospective outcome study published by TMH, it is prudent to target both, either sequentially or concomitantly or together. So the OS benefit was significantly higher when you target both EGFR and ALK rather than targeting only one. That is a TMH study. But whether you're going to do it sequentially, first ALK and then EGFR, or first EGFR and then ALK, it doesn't matter. But at least both of them has to be targeted based on that data. But patient clinical characteristics, I think you would be a better judge to say.
Arun, see here, we need to see what is the driver mutation, which is the first one, because PS is bad. Okay, if we cannot, we need to select which mutation to target first. So will that 28 reads give any signal to you? See, we know VAF of 5% when the tumor fraction is 30%, probably it's a subclone. Not all tumor fraction is having that TGFR mutation. But this 28 reads, what is the significance? How can we interpret that? How significant is it?
Unfortunately, we cannot do that, doctor, because 28 reads out of what is a question, and we cannot directly have a percentage there. So I would not be able to comment whether 5.2% of EGFR is more, or the 28 reads of EML4 ALK is more in the tumor specimen.
Sir, if I can ask, which would be an ideal read count?
That's what. It's very subjective. It's very subjective. And it varies from experiment to experiment. Maybe back, in the back, we can see if there are the depth of sequencing is given. However, even then, one cannot say with surety if EML4 ALK with 28 reads is the driver, or is a larger clone, or 5.2 reads of EGFR is a larger clone. So, okay. But ALK fusions are generally targeted first, if clinically, compared to EGFR, because of the propensity for CNS metastasis and the aggressiveness that it may have if it goes untreated. That has been what I have understood. But otherwise, EGFR versus ALK, I don't know which to prefer based on the molecular report given here.
Hi, sir. Dr. Dinesha here. I just want to add a point here. So with respect to the fusions concern, so anything about 20 reads is considered as positive. So in this case, the number of reads what we have got is 28. And so comparing these two variants, EGFR versus ALK fusion, so what I consider is the EML4 ALK fusion is considered to be the dominant strain compared to the EGFR. And maybe what we can do is that we can do IHC to confirm the ALK positivity. And
Dinesha, why did you tell ALK is the dominant? Can you just again come again?
So the general criteria is that, sir, and the number of acceptable read, if the number of read is about 20, it is considered as positive for the fusions.
Okay.
So that varies from lab to lab, Dinesha. Correct. Sorry to say, but it is not a universal thing to say 20 and above is positive. You can even target if there are 5-6 reads and the patient would still respond. So there is never a standardized cutoff for the number of fusion reads.
Okay. So
Hello.
Yeah, hi
Hello.
Nadim. Hi Nadim, Kripa here.
Hi,
So
sir.
yeah, hi Nadim. So nothing. I mean, like, so was the RNA sequencing also done here, or was just the
No, sir.
DNA sequencing alone?
No, this is the only report we have. The earliest,
Okay.
quickest panel the marketing person marketed.
Okay. Okay. So
This
you
is
know,
RNA included, sir. I know.
oh,
This
it
does
is
have
RNA
RNA.
included
Yeah.
as well. Okay, fine. So they haven't mentioned the transcript in particular because this is the V1, V2, or V3 transcript that usually is associated with EML4 ALK fusions as well. So just
V1,
wondering why.
V1 exon 13 of EML4.
Okay, it is V1. Okay, fine.
Uh,
So I think, you know, whenever.
Can you hear Dr. Kripashankar?
Okay.
we lost him. We lost
Can
him.
you hear me now? Yeah, can you hear me now? Yeah.
Yes, Kripa.
Yeah. So I think, you know, whenever, see, usually we say IGFR and ALK are considered to be mutually exclusive, but then they can overlap in around less than 1%. So here is one of those most commonest, you know, encounters that we actually have to happen with EGFR and ALK co-mutations. So having said that, when you pick up an EML4 ALK fusion, which is the most commonest fusion that's been reported with the V1 transcript, I think we should look at targeting the ALK. But having said that, if you want a drug that can act on both, I think we've had this discussion earlier as well.
I think we are losing Kripa in the middle.
Hello?
Yes.
No, am I audible? Yeah.
Yeah. We are losing in the middle. Yeah.
Sorry, sir. So if you probably are looking at a drug which can act on both, then brigatinib would be a good option because, you know, you're not only having an action on the ALK inhibitor, it's a second generation ALK inhibitor, but it's got activity on EGFR as well. And the dosing goes something like this: you start with 90 milligram for the first week, and then.
So Dr. Pushpa here.
Having said that, hello. Yeah. So if you probably, you know, you're just choosing to go with brigatinib, then I would just probably look at doing brigatinib at 90 milligrams and wouldn't want to escalate to 180 milligrams and keep it at 90 milligrams as far as treatment decision making is concerned. And like Arun has rightly pointed out, I think there are different cutoffs that are used as far as the number of reads are concerned with each lab and each sequencing as well. So I think here, when you have both, I would look at, and another reason as to why you probably want to target the ALK first is that we know it's got a slightly better prognosis. The response rates are higher when compared to EGFR inhibitors. And that's why, you know, as far as the sequencing option is concerned, especially in your patient, I would not want to give both together because of the risk of toxicity. So I don't think that will work for your patient who's already PS3 elderly morbids. So I think I would probably prefer to go with brigatinib here, given that it's got an action on EGFR as well.
Okay.
Sir, here I have one suggestion, sir. Actually, like this particular report has been done by using Ion S5 platform, where 20 is the basic cutoff. So anything above that is 20 is considered as positive. So here 28 is still the borderline. And I would consider EGFR. Why? Because they have already done a PCR and it is PCR, it is showing positivity. And NGS has also picked it up. Before going for EML for ALK, better to do an IHC testing before proceeding with EML for ALK would be my point, sir.
And the other thing is probably, you know, when you talk about IHC, you know, D5F3 antibody and the Ventana platform, we know the concordance between ALK and FISH is not 100% as far as fusions are concerned. So, you know, we know the concordance is close to 90%, but it's never 100%. So, you know, why not a FISH over a IHC, you know, to the molecular oncologist here?
Yes, when that is the case, like compared to IHC, FISH is better. And considering the presence of the nodes, maybe like we can even go for an NGS because that will have more sensitivity. Just for like IHC would be like quick. So that is why I said EML for ALK IHC.
Exactly. But then the problem again, like we've just been discussing, is that, you know, it's not 100% concordant. And like you also rightly pointed out, you picked up an EML4 ALK fusion, which is above the reads that are classified with this particular lab on this report. So I think we should take it as positive, right? It's a V1 transcript and exon 13 as well. And it's a very rare scenario, obviously. Like I said, less than 1% who are likely to have both co-mutations. Well, if the patient can afford to get it done, I would also push definitely for a broader NGS panel or comprehensive genomic profiling as well to look at other co-mutations that could have evolved. or to look at whether it's a clonal or not. But I think all said and done, even in the Tata paper, as was quoted by Dr. Arun, they did allude to the fact that you could either do it concurrently or sequentially. The reason why we believe here it should be sequentially is that because of the age, the performance status, and the comorbidities of this patient, who's already 78 and in PS3. So I think it's, and obviously, as far as targeting EGFR or ALK is concerned, the reasons why we probably in practice would like to choose ALK before EGFR is because of the prognosis. See, the median survival, for example, is around 38 months with osimertinib alone, whereas we know it goes beyond 5 years with any of your third generation ALK inhibitors like lorlatinib. So I think given that as well, that's another point as to why we should look at probably going that way. And then at progression, contemplate doing a repeat NGS or a CGP, and then look at identifying the target resistance mutation as well, and then take a call based on that.
Yeah,
This broader gene panel, how will it help us? Very, very layman question, sir. Broader gene panel, how is it going to help us, sir, more?
See, like for example, when you do reflexively both together, we call this, complementary testing, right? Tissue plus liquid. You could get that done to look at, seeing if the same picture is being carried there as well, or if there are additional mutations which you can pick up. And again, like for example, standardized labs. I'm talking about probably, Foundation, Tempest, Guardant, any of those labs as well, which reflexively do both together. So if you can, and probably for lung, I have a slight preference for either Guardant over Foundation. That's just my personal preference. So, but you could definitely, you're free to choose between any of this, including carriers as well. But I definitely would look at doing that just to see if it's the same sort of picture that's happening there as well, or if there are additional mutations that have evolved. And again, look at, the number, the depth of the sequencing, number of reads, all of that. Is that being, is it concordant again? So I think that would be.
I agree with even initially I said a broader gene panel will be better, at least in this case. See, one important point is here EGFR is a subclone. It's not the main clone. So even if you are thinking of EGFR based treatment only without chemotherapy, only EGFR based treatment, I think it may not be good for this particular patient.
Absolutely, sir. Completely agreed. See, this is an exon 21 L858R and not an exon 19 deletion. Conventionally, EGFR TKIs respond much better if you have an exon 19 deletion, whereas here is a exon 21 L858R mutation where combination strategies are the way forward. Either you do amilazatinib or you do OC plus chemo. And obviously, this patient is in no state, to probably get chemotherapy given her performance status. So I think in this scenario and in this condition, an ALK inhibitor, especially something that's got action on EGFR as well, like the second generation brigatinib, like I just suggested earlier, at 90 milligrams without escalating it to 180 milligrams after 1 week, would be my choice. I would probably look at it like that.
I think I agree with Kripa. Either brigatinib or start on lorlatinib, sequentially plan for EGFR based on the response. That is combining both EGFR. I am not for combining because of the poor GC, elderly patients, and not much of data. So probably sequential will be better. Brigatinib, if possible. Otherwise, lorlatinib may be my choice.
Agreed. I think, brigatinib, now that Takeda has launched the drug in India, earlier we never had access to brigatinib, so that was a challenge. Now we have access to brigatinib. It's been launched by Takeda. It's commercially available as well. Albeit, slightly more expensive. But it's almost as expensive as lorlatinib, so yeah.
Thank you.
Yeah.
Pushpa,
I just have a point.
Push.
Yes,
Yes.
Sir, so generally in EGFR and ALK co-occurring mutations, especially in lung adenocarcinoma, generally ALK is considered to be the main driver if you look at the data, basically. So when it comes to a therapy, I agree with the doctors again. The ALK inhibitors will be the first line of preference. And here I would like to also suggest not only concurrent testing, like solid plus liquid, basically to understand the resistance like T790, suppose in case EGFR is one of the choice, and also other any resistant mutation occurring, which may be probably got to be known in liquid biopsy, as well as along with the RNA analysis will be choice of test basically when it comes to the fusion confirmation. And since here only ALK-EML4 is there, if that is the only mutation to be or a fusion to be considered, then I think FISH would be the choice for the confirmation. But here, since we have already the reads greater, I think going ahead only keeping this report will be doing. And for me, again, the first choice will be the ALK-EML4, keeping in point of view as a driver mutation, and the inhibitors choice maybe the ALK inhibitors, and like the Krupa said. And EGFR, if suppose is to be planned, then I think the concurrent testing will help here.
Okay, so
Thank you.
I
Thank
just
you.
had a point, Dr. Kripal.
Yes, sir.
Like you mentioned about doing the orthogonal testing or the other testing for ALK using FISH, but I think although the concordance between IHC and NGS may not be as high as what we expect to be, but IHC gives you the add-on benefit of identifying if this really translates into a protein expression. So in my mind, I think I may edge more towards doing an IHC as an orthogonal rather than FISH, because NGS has anyway picked this up, and in all probability, this translocation would be picked up. If it's a break apart probe, it would be picked up in the FISH. So that's my thought process. I thought I would share it here.
No, completely. I think, most
Agreed.
of us do that as a screening test. IHC as a screening for ALK, like right when the patient enters. But like has been rightly pointed out there, like this patient has already had an NGS, and the report, like based on the cutoff from this particular lab, which says more than 20 reads is positive. I think NGS, especially with an RNA sequencing done as well on this report, I think for me, that's probably good enough for me to offer the patient ALK inhibitors.
No, hello.
Yeah, hi. Hi, Nirmal. Yeah.
Yes. So ALK comes false positive many of the time. So it is very rare that ALK and EGFR are positive at the same time. So I think you should check it by IHC.
But how often do we get a EML4 ALK fusion with a V1 transcript on exon 13 to be positive with 28 reads? How often do we get that, Nirmal?
And IHC is attempted. It is not. It is unable. They are unable to do it. We have to redo a biopsy for IHC.
Oh, okay. That is a problem.
I think, NGS,
Just for your,
between
just for,
NGS and IHC, what would be the concordance? I'm just saying, what would be the concordance of IHC on ALK versus NGS? Which should be the gold standard? Even if, just wandering out loud here. Nirmal?
I would say 90%.
And I think, between IHC and FISH, it's 90%, but slightly lesser than that, as far as IHC and NGS is concerned. But nevertheless, I think we've really done a sequencing here with which contains an RNA sequencing as well, and you picked up more than 28 reads, which is above the detectable reads, more than 20 for the cutoff for this particular lab, and they've reported it as positive. And they've also mentioned the transcript, which is positive V1 transcript on exon 13 as well. So I think for me, I would be comfortable in offering this patient ALK inhibitors, because
see,
there's nothing to suggest
I
that here
just
that it's a false positive.
to Arun Kumar and other pathologists also, I just want to see if ALK IHC wise, it's positive can happen ALK overexpression or fusion also. Okay, but ALK overexpression leading to IHC positive, probably ALK inhibitors is of no use. So here already you have a fusion. So even if IHC is negative, then still we will take it as false positive or false negative, and we need to challenge, or we need to give the patient ALK inhibitors, right? In case IHC is negative in this case. Okay, what will be your next line? What you will do with this patient next? Definitely you will go for FISH, right?
Yes, sir. So
Yeah,
let me
definitely
try
you'll go for
to
FISH, right?
tell that in a sequential reason. See, number one, I am completely aligned on the fact that this is RNA sequencing, so this is good enough to go in for a ALK inhibitor. But the whole confusion comes in, what if it's a false positive, because you also have a very rare combination of EGFR and ALK together, so you want to be doubly sure. That I think that's the whole reason why we are even thinking about a second testing methodology. If not, this ALK report is good enough to go for a testing. Now, if I would go for if at all that doubt is there, go for IHC. If IHC is negative, because we do know there is a 10% discordance between IHC and NGS, then I would go for FISH.
No, exactly, Arun. Why not go directly for fish? So if
Huh.
fish is positive, you are going to accept anyway. Why to go to IHC, then come negative, then go for fish? Why not directly go for fish and put the patient on ALK inhibitors?
Because
Yes, correct.
IHC gives us protein expression which takes precedence over genomic alteration, which is anyway detected by this NGS.
Correct. But if it's negative, anyway, you are going for fish, right?
Yeah, because
So why not?
IHC takes precedence there.
Okay. Okay. So
I think as a stepwise algorithm, it should be the other way around. Start with IHC, fish, and then NGS, and we are going in the reverse order.
We are going in the reverse order here. Yeah.
So,
No, I'm very comfortable with this report of NGS positivity. It is for those, if at all you have a doubt, then what is the question?
yeah, because I think the hierarchy is something like this. I mean, like IHC, fish, and NGS, one above the other. So I think I'm comfortable
So
with that.
can we repeat an NGS from some other lab?
We already spoke about that. We spoke about doing a broad-based NGS, both tissue plus liquid as well, complementary testing. We definitely did say that that's definitely a possibility. We could definitely look at doing that.
Definitely, because see, the whatever lolatinib or brigatinib, all these things are quite expensive molecule. Before starting, by going for a comprehensive genomic profile is always good. That's what if the patient is affordable for brigatinib or lolatinib, going for a
They will be able to
comprehensive
afford.
is always a better choice.
Agreed.
So patient is affordable, and I'll do a complementary testing and then represent and we'll rediscuss, sir. For now, I've started lectinib, and after this discussion, wants to add maybe some EGFR also.
Are you sure your patient is PS3 and can take both together, Nadeem?
I'll see, sir. Let's see.
So I think the prudent strategy would be just to go into the ALK inhibitor alone, watch for the response, see how she responds, and then take a call. Because if she's responding well to only your monotherapy, then you may not need to add another EGFR inhibitor as well in there.
Okay, sir. Okay, sir.
Yeah.
So thank you everyone for this great insights. So as far this case is concerned with ALK and EGFR positivity, to consolidate what everyone, all the experts have given their opinion. So either we can go by secondary testing with FISH, IHC or FISH, and also a comprehensive genomic panel, and consider sequential therapy with the EGFR if based upon the response subsequently. So thank you, everyone. So moving on to the next case. This is by Dr. Muthu Manigandan from Meenakshi Hospital. Case of CEO endometrium. Over to you, doctor.
Yes, ma'am. So good evening. So my patient, she's a 58-year-old female. It's the case of carcinoma endometrium, stage 4, and known case of diabetes and hypertension. Next one. Next slide. So she's diagnosed in 18 December 2029. So she was initially treated with magistral acetate for 2 years from outside hospital. So and she underwent staging laparotomy with EBRT and IVBT in 2021. Because the lung nodules were stable after the 2 years of magistral acetate, so she underwent radical treatment, and she was on follow-up. And then in November 2024, there's a metastatic recurrence. So subsequent treatment, she received 4-cycle of nanoxyl carbo oral etoposide for 6 months, and then again there is a progression. Now she's currently on lipodose carboplatin. 4 cycles she's received till now. Next slide. So the biopsy was done now when there is a recurrence after etoposide. So it was done from lung. So the histopathology is adenocarcinoma, and IHC CR positive, TTF4 negative, and PAX8 positive. So likely a metastatic endometrial carcinoma. So next slide. And so I'll come to the NGS report first, then I'll discuss. So this is the NGS report. It shows CTNNB1 mutation and PTEN mutation. There's 2 variants. So there is a two variants. One variant is VAF, VAF is 56%. And another variant is 24%. So now coming back to the question, previous slide. So now the question to molecular tumor board is the whether clinical relevance of dual PTEN mutation, and does PTEN mutation with VAF more than 50% suggest germline origin, and is germline testing is current indicated for this patient. So the patient is currently on lipodose carboplatin, 4 cycles completed. So she's due for next PET-CT, next imaging evaluation. So the further management, I'm asking after this molecular tumor board discussion. So that's the questions. Yeah, this PTEN mutation, there's two variants. These are the two variants which I already mentioned mutation. These are the other mutations. I mean, same thing. Some VUS was also the APC. That's so, and this patient is MSI stable. Yes, sir. So my question is like, what is the relevance of dual PTEN mutation, clinical relevance, and germline testing, whether it's indicated because one VAF is more than 50%? Yes, sir.
Okay, so maybe I'll just give my comments. I'm Arun Kumar here. So this PTEN, particularly about the PTEN, there are two PTEN variants, one with 56% VAF, the other with a VAF of 24%. This particular variant, tyrosine 336 termination variant, which is a 56% variant, I checked the databases. It has not been reported to be germline till now. So if at all it's a germline, it's a very rare possibility it's a germline, but it is good that you identified it's a 56%, so nothing wrong in testing it. But however, it's very rare to see a PTEN germline variant, that too with a termination variant. So there's not a amino acid change, but it's a termination. Tyrosine, it's terminated there. So that means that it's a pretty pathogenic variant, and I'm sure if that was a germline variant, the patient would also should have had other features or other malignancies or other disorders. Nevertheless, because it has not been reported, you may want to do a germline testing for that particular variant. And I think age of onset has also been in the 50s, right, or early 50s. So that is my thought process here.
Okay, sir. Thank you, sir.
Thank you.
And maybe because just extrapolating it, is this a result of previous anti-hormonal therapy? Whether this is kind of a resistance to that, I don't know. The timeline sequence I didn't correctly capture, but is it a sequence of that? I'm not sure. But nevertheless, this is worthwhile to test for a germline variant.
Okay.
Just
Okay,
want
thanks.
to add,
Yeah.
Dr. Jaren here. So this patient is undergoing systemic therapy under my care, and they came yesterday with the PET. PET is actually showing progression in the lungs and also pleural effusion. So, is there any role for targeting this particular thing? Just wanted to ask that in addition.
Okay,
Hi, Jaren. Go ahead, sir, please. Sir.
No, please go ahead, Dr. Krupa. I'm sure you're alluding to the same point. Please go ahead.
Sure, sir. So, hi, Jaren. So, this patient's got a PTEN loss. So, that that obviously that means the PI3K mTOR pathway is activated. So, we could look at doing letrozole plus everolimus. There is data for that as well in, an endometrial cancer, especially that's driven by PTEN loss, number one. But having said that, here, this patient has progressed after a.
You lost Kripa. Yeah, I think what Kripa is telling is the PTEN loss is there. So PIK3 mTOR pathway. That one option is letrozole everolimus. The other is, I think, fulvestrant and capivasertib. These are two options in that pathway. And pembrolizumab, I think immunotherapy patient, even in MSS stable, in keynote study, pembrolizumab also is an option. So pembrolizumab, or if the PTEN loss we are taking, probably letrozole everolimus or fulvestrant and capivasertib. These may be the options based on the PTEN loss. These are some of the options I was thinking. I think others, Arun.
Yes, sir. I also think in the same lines, because I was thinking of immunotherapy for this patient. But maybe Dr. Kripa can shed light on this. In the pembrolizumab study, I don't know how many had such large metastasis or multiple. I mean, this patient has pleural effusion. So, doing that alone, would that suffice to curtail the tumor is a question, or would you want to do a platinum immunotherapy combination? Is something I just want to
Patient has progressed on platinum because patient
on
has
plat
given multiple
Lipodex
lines
and carboplatin.
carbo.
Yeah.
Just now he has progressed on platinum. So how is the GC of the patient? Is she fit for further chemotherapy lines?
Actually fit for treatment, but very apprehensive on actually IV treatment currently.
Okay. Okay.
Information
So
got
yeah.
it. The attender came to discuss with me.
Okay. Okay. So GC is good, right?
CPS1.
Okay, okay. So I think platinum resistant and ER positive and PTEN loss is there. If they want to, because we know that its intent is probably another 6 months or 8 months. If it works, probably we can prolong. These are two lines, either immuno or we can target the PIK3 pathway, AKT mTOR pathway. These are two options. So further lines of chemotherapy probably may not because platinum resistance options are very, very minimal.
Dr.
Naren,
Pushpa,
yes, ma'am.
and Dr. Pushpa ma'am wants to answer. I
Yes,
think
yes.
Uh, Sir, as there is biallelic inactivation here of the PTEN mutation, basically, so that condition generally leads to your oncogenic activation of PI3K-AKT mTOR inhibitors. So, keeping in that point of view, I think MET inhibitors should be one of the choice. My consideration here is CTNN beyond one present. Most of the times, it is one of the resistant marker which is causing resistance to immunotherapy. So, but in combination with other drugs, maybe I think it will work. And you have to give the expert opinion for that. But here, straight away, there is an oncogenic activation of this mTOR pathway. So, why don't go for mTOR inhibitors here?
So I think, ma'am, if I can answer that, so the strength of evidence or the data, see whatever we're talking about as far as blocking the PI3K mTOR pathway is concerned, that is everolimus plus letrozole. That's the data that we have. It's not as strong or robust as the phase 3 randomized control trial that we have, the Keynote 775, led to the approval of pembro plus lenvatinib in this setting, especially once the patient has progressed and now becomes second line in the metastatic setting. So I think, Jaren, the patient has progressed, right?
Yes, sir. Yes, progressed.
Yeah, and if there are no financial constraints, then based on the current data, evidence, and whatever level 1 data that's there, consensus is that you should look at doing pembro and lenvatinib. That's the go-to choice in the second line setting. In the metastatic setting, I mean, if patient has got no financial constraints, but does the patient have any financial constraints?
No, sir. I think they can. Only thing is she's a bit apprehensive of infusions as of now.
Okay, so you can probably talk to her about the recent pembro data as well, where you can do shorter infusions, start with 30 minutes, 15 minutes, and then 10 minutes, in the subsequent infusions. So you can try and convince her for that pembro lenvatinib, and then probably look at using evro plus letrozole plus everolimus later on as part of maintenance strategy, because if you're looking at blocking the PI3K-AKT mTOR pathway based on the PTEN loss.
Sir, do they have this pembrolizumab? Do they have the PTEN mutation data with any aggressive mutations data in them?
Yeah, again, they included all histologies as well, Naren. And they did not exclude patients who had PTEN mutations. So if you're going to ask me the exact number of patients who had if you're going to ask me the exact number of patients who had a PTEN mutation, I don't know. But definitely not an exclusion criteria. So you don't have to exclude patients based on the presence of a PTEN, as far as the data, the Keynote 775 is concerned. So they did include, but there was no subgroup analysis done looking at only PTEN mutations alone. And even if so, that would only be an exploratory subgroup analysis, Naren. So that may not be powered adequately enough to answer a question of whether we could do it, particularly in patients who have a PTEN loss. So I think current standard of care, as well established with the current guidelines and consensus, is that pembrolizumab once the patient has progressed on a platinum-based doublet in the first-line setting for metastatic endometrial cancer. I think that's just my take, and welcome to other suggestions as well.
Any other opinions from anyone? Dr. Sivashankar, you want to opine?
Like I'm
If not,
what Dr. Arun sir had said, ma'am.
So have you
uh,
checked for the family history here also, Dr. Jarin?
so to conclude about that case of CA endometrium with the PTEN mutations, would probably go ahead with either immunotherapy with lenvatinib combination, or and also consider germline testing also if needed, and we can also consider the downstream pathway inhibiting the mTOR along with the mTOR inhibitors. So thank you all. So moving to the next case is by Dr. Ali Azhar from Indira Gandhi District Hospital, Kavarati. Please, over to you, sir.
Thank you, ma'am. Good evening to you all. I am Dr. Ali from Lakshadweep. We have only district hospital, that is Indira Gandhi Hospital in Kavarati, Lakshadweep. And I thank you for giving me this opportunity to present my case. So this is a case of 43-year-old female presented with abdominal pain, recurrent abdominal pain for more than 2 months. So they did one MR scan from mainland, which showed, I think MR scan report is below. It showed that cystic lesion in right fallopian tube and the ovary, which measures 7.9 into 4.45 into 2.62 centimeter in size. And another lesion was there in abdominal wall, which measures 7.6 into 3 into 4.7. So the gynecologist, they exploited these abscess. It was actually pus producing abscess. The report was abscess. So they explored this abscess, and they opened the abdomen. They could see that this mass abetting all the structures, uterus, bladder, everything is. So they removed as much they can remove. So they did a bilateral salpingo-oophorectomy, and they cannot go for a total abdominal hysterectomy. They only did bilateral salpingo-oophorectomy, and they sent the sample for pathology. So the biopsy date was 3rd December 2025, which specimen showed right and left tubes with ovaries, and histopathology only said that the suspicious for low-grade serous carcinoma. And I could see the IHC report. You can see, so they only said that right and left tubes, which is only having low-grade serous carcinoma, and right tube is suspicious for low-grade serous carcinoma. And tumor measures 1.7 centimeter in right tube, 1.5 centimeter in left tube. So the biopsy from abdominal wall, it is abscess formation. And this is our diagnostic problem. So we want to proceed. How to proceed? The question is, what are the IHC we should recommend? According as per the IHC, we could proceed.
Okay.
Is any other molecular testing? We need to know the primary site, ovaries, it's from ovaries, from fallopian tube, or is from endometrium, because we couldn't remove that uterus is still there. So is there any evidence of metastasis from another primary based on morphology and or IHC? Is there any molecular testing indicated for prognosis and target therapy? These are the questions we put before molecular tumor board, sir.
Okay.
I think we have a pathologist, Dr. Chandramouli, ma'am. Probably she take if she's there. She can probably
Yes,
take
sir.
this.
Yes.
Yeah, ma'am. You can take the IHC part of it.
Yes, sir, I went through the report actually, but it is clearly mentioned that the ovary is not involved in the histopathology report, as well as in your MRI, there are lesions in the tube is what is mentioned as per my understanding. Please correct me if I'm wrong. So tube has a lesion and there is a para-ovarian cystic lesion, and then there is a mass like how you described, no, the abscess cavity.
Yes,
and
yes,
then the histopathology report also mentions that sections were taken from both the right as well as the left fallopian tubes,
Yes.
and both the right and left fallopian tubes only are showing carcinoma. So ovary, there is no mention of a malignancy, correct?
They're saying they're suspicious for that's
Yeah,
sort
I
of.
understand that. I understand that. The coming to that, fallopian tube low grade serous carcinoma is a very, very rare entity. High grade serous, had they reported, yes, it is definitely acceptable because all of us know that there are precursor lesions. Whether the tumor is in the tube or in the ovary or in the peritoneum, high grade serous carcinoma is known to arise from the fallopian tubes. But this is reported as a low grade serous carcinoma. So the pathologist, I think you need to talk to the pathologist and find out how sure they are. Like, are they suspecting any high grade lesion over a low grade lesion? And that is why they have worded it as a suspicious for low grade carcinoma. You can inquire. Otherwise, it is a tubal carcinoma, is what I understand from here. IHC will not help. Only histopathology has to give an answer here.
Okay.
Okay, ma'am. So you think probably it's like a stick which is progressed, ma'am?
Sir, yes, stick and still are for high grade serous carcinoma, sir.
Yeah, correct.
Here
Correct.
what,
Absolutely. It's a precursor for
they
high
have
grade.
written as low grade serous, which is the confusion. So probably you can have a word with the pathologist. Is there any high grade histology and other things? Because they have written
Any IHC markers, no? Any IHC markers that you would probably suggest?
WT1, you can go for WT1, sir, which will be positive in a high grade serous carcinoma over a low grade serous carcinoma. Beyond that, IHC is not going to help us, sir.
Okay.
So I spoke to this NDC 125 is normal, ma'am. So I spoke to histopathologist. They are saying that they will go for a final diagnosis IHC or something like that. So that they said, ma'am.
No, can you please ask them if they are sure about the malignancy? Because suspicious is a very vague terminology.
Yes,
are they sure about the malignancy or not? You have to ask them. And then about the grade, whether it is low grade or high grade, how sure are they? What is the IHC for? Is it to confirm the malignancy or is not to grade it?
They're saying the final diagnosis IHC, like that they said to me. Final diagnosis IHC, they will do some IHC tests till the final impression, final diagnosis comes out, like that.
But yeah, I understand. But here I don't know how it's going to help us. Is my viewpoint.
Dr. Arun Seshachalam here. Thank you. Nice to hear from you from Lakshadweep. Thank you. I think this case, probably a second opinion from your oncopathologist sending across, and that will help in this particular. Here, pathology is the key. So taking one more second opinion from your oncopathologist will definitely help you more than going for a molecular testing. That's what my opinion in this case. Let's see what others.
It means slide review in
sending the blogs, and that will really make a difference in your case. That's what I think.
Sure. Thank you, sir.
Thank you, doctor. Thank you for that presentation from your place. And so we'll actually ask for a repeat opinion for the same from oncopathologist nearby. So moving on to the next case is by Dr. Balaji, sir, from Kamakshi Memorial Hospital. Case of CA lung. Over to you, sir. Balaji, sir?
Yes.
Yes, sir. Yes, sir.
I think this is the third presentation. Actually, we treated this EML4 ALK fusion positive with P53 co-mutation with first cycle of chemotherapy, then radiation, then followed by lorlatinib. This patient seems to have a good CNS control and also thoracic control. But the patient is tolerating poorly. Patient developed a GBS-like syndrome, demyelinating polyneuropathy. We have given the IV immunoglobulin also, and we reduced the dose of lorlatinib from 100 to 75. 75. And we with immunoglobulin and reduced dose of lorlatinib, the patient was recovering. Patient had a full recovery of the facial nerve. Now the power of the lower limb has also increased, and the patient is walking with support as of now. And we have done a PET scan today. Chest X-ray, everything showing a near complete response. So I want to know whether we can switch over to a lower generation or de-escalate to a lower dose or give a treatment-free interval till complete recovery.
Have you done any antibodies, sir?
Yes.
Antibody work?
Yes, I have done paraneoplastic panel also
Okay,
and anti-ganglioside. You please read.
Ma'am, we have actually done paraneoplastic panel comprising of ANNA 123, PCA 123, and AGNA, CRMPS, amphiphysine, and also anti-ganglioside antibodies, ma'am. But everything was negative. But since a neurologist told it is like GBS like things, we have given 5 days of intravenous immunoglobulin, ma'am. We have checked with the lorlatinib brand also. They are also not telling whether this is related to the drug. That's why, ma'am. But in the last response assessment scan, CT thorax taken, there is a good reduction in size of the primary lung lesion and also the mediastinal nodes, ma'am.
So yeah, hi, Kripa here. So, if you feel that this patient has responded well, and obviously your neurologist feels that there is some sort of demyelinating neuropathy, and you've done extensive, paraneoplastic antibody workup as well, and all that has been turned out to be negative. I'm sure you've done a CSF cytology as well. Is that negative? And how many CSF cytologies have you done?
No, we did a MRI brain and spine only.
Okay, sir. Okay, so probably I would suggest that you could probably get a CSF cytology as well done. Probably if you're looking at leptomeningeal disease or leptomeningeal enhancement or anything like that, you could look at ruling out disease involvement by doing a CSF cytology. But if the patient has responded at all other sites, and if you feel that probably the disease, like the drug is what is causing this, then I don't see harm in actually coming down on the dosing from 100 to 75 milligrams. But more often than not, lorlatinib does cause cognition issues. It's more related to cognition, edema, all the GI adverse effects as well.
Yes.
So, whatever that we're talking about, demyelinating neuropathy
Yes.
is likely to be unrelated. So that's my take on it.
Yes. NCS shows a demyelinating type of.
Correct, sir. So we have definitely evidence in that there is definitely evidence of demyelination here. Demyelinating, is it axonal or?
Axonal, sir. Yes, sir.
Is it axonal? Okay. So then I think I would definitely concur with probably coming. And you're saying that the patient has responded well to all other sites of disease, and the patient is already on IVIG as well for the GBS-like picture.
Yes, and the CNS control is perfect. We repeated the MRI of brain and spine.
Right. So then I think this is the only other thing that probably I would like to add or suggest is you could also, for completion's sake, get a CSF cytology also done. Rule out CNS involvement. That's the only thing.
Okay. CSF cytology for any liquid biopsy of the CSF or anything like that?
Nothing, sir. First for cytology alone, because only if the cytology is positive, then we could look at doing a cell block and go on and so on and so forth. But if the cytology is negative, then you could probably do 2 repeat samples. Just make sure that the your lab gets the sample within a few minutes, because then the cytospin assay becomes very important. Otherwise, you can miss out on these atypical cells, sir. So that's the only thing as far as the stage of cytology is concerned.
Well, are we attributing this demyelinating polyneuropathy to drug or different? If it because of drug, if it is the drug, then this will be like grade 4 less. Toxicity we should not reach challenge, right?
Yeah, so Narendra, I just checked the data also. Actually, when I saw the case, it's a very rare, but still it's possible. Autoimmune polyneuropathy with lorlatinib, but it's very rare. Paraneoplastic because of lung is more common than drug-related polyneuropathy. That's what it's given. So the option is we don't know because it's negative. All the antibodies, whatever their panel is negative. So first possibility is paraneoplastic. Second possibility is drug related, but definitely we cannot exclude. But the chances of drug related is very, very less, and the patient has done very well. So our option, what we have, I was just thinking, the patient has done very well with the tablet. So either we should change lorlatinib to probably another ALK inhibitors, that is first, or try with a reduced dose, see how the patient is doing. If the patient is still deteriorating, probably we need to stop the drug and change to other ALK inhibitors. These were some of the thoughts what I was having after reviewing the whole case. It's a very unusual case, I think, but it's quite difficult to manage.
Okay.
Yes, sir. So I think I would completely agree with what Arun sir is also saying. I think, you could look at trying to come down on the dose of lorlatinib to probably around 75 milligrams, see how that goes. If it's still persisting, then you could probably look at even giving a TFI and then switching over to another second generation ALK inhibitor. If you think it's probably related to because it's a diagnosis of exclusion. Drug induced here is only a diagnosis of exclusion, as you rightly pointed out. It's very rare. Doesn't happen that quite commonly. Much more
Patient
common, of
has
course.
motor. How is the motor and other deficits recovered, sir? Completely recovered.
Completely
Because
recovered. Facial muscles have completely recovered.
Okay.
Proximal, distal muscle also. Proximal weakness was there for 1 week. Now it is also improving. Almost 3 to 4 by 5.
Walking without support. Couldn't walk with. Okay. Okay, sir.
Thank you, sir. Thank you for updating regarding this case, sir. And to consolidate what we have discussed regarding this case is that probably it is a paraneoplastic syndrome or it is drug related. And drug related, though it is rare, can happen. And as of now, since the patient is doing well with the immunoglobulins, we can either de-escalate the dose or switch over to another ALK inhibitor subsequently based upon the patient's performance. So next case is by Dr. Narendran from Tiruchi. Over to you, sir.
Next slide. This patient, 51-year female, she was diagnosed with a dual malignancy. One is right breast metaplastic carcinoma, mostly of epithelial type predomination was there, with the papillary carcinoma of thyroid. So upfront surgery was done for the both disease. She has family history of mother and father diagnosed with a lung cancer, both not related to each other, not of consanguineous marriage. And with histology, carcinoma, it is stage PTE1C N0, and for the papillary carcinoma thyroid, it was low risk. So after surgery, she was follow up. For metaplastic carcinoma, we have done a adjuvant chemotherapy followed by radiotherapy, and we are treating in lines of triple negative breast cancer. So currently, she is on capecitabine. We have sent a BRCA1 and BRCA2 germline. Next. So papillary carcinoma, it is low risk, so she is under follow-up. For BRCA1 and 2 report, can you show the report? So this is BRCA1 is negative. BRCA2 is reported as a variant of uncertain significance. So with a mother as a family history of mother as lung cancer, father as lung cancer, and she is diagnosed with a dual malignancy. Actually, with this report, we wanted further to go for a comprehensive germline cancer panel, but financial reasons we couldn't do. So so many malignancies, what could be the additional mutation possible here? And recently I had a paper where they said that BRCA1 and 2 had relation. If germline BRCA1 and 2 is there, the chance of lung cancer diagnosed before the age of 40 is more. The retrospective study from Japanese study is there. So how relevant is that? Because we have seen in our previous molecular tumor board, many lung cancer, when they do go for a testing, they incidentally they diagnose with the BRCA1 and 2 positive. So whether that is incidental or whether it's definitely a relationship is there here. So these are two questions. So this is my question here. And academic interest, if possible, any lab comes forward for the comprehensive germline panel for this patient, we'll be happy. Thank you.
Sir, Dr. Pushpa here. Recently there was a ASCO guideline which I have sent in the group. People can see now there, where they have mentioned in lung cancer, basically they are looking into BRCA1, BRCA2, ATM, CHEK2, and MITUH MUTYH mutation basically, and they are being the predominant germline genes there. So for a lung cancer now, BRCA2 mutation is again considered to be one of the proper germline mutation there, or a dominant germline mutation. So I think comprehensive CGP will also further help here.
Okay.
Sir, for this particular case, sir, they have identified the variant of uncertain significance. When we look at the ClinVar history and multiple labs have also classified this variant as a benign variant. The BRCA1 and BRCA2 association with the lung cancer, yes, it is coming up, but it is associated with pathogenic or likely pathogenic variants. Mostly BRCA1 and BRCA2 loss of function variants are mostly the pathogenic or likely pathogenic variants. So here, considering this VUS, this VUS may not be associated with the lung cancer, but there are other genes also. As Dr. Pushpa Singh ma'am has pointed out, there are other genes also. Not just these genes, even some of the EGFR germline variants are associated with the lung cancer, but they have a different penetrance level. They have a moderate penetrance. So, a comprehensive hereditary cancer gene panel with MLPA would be the best option, sir. If at all, like any deletions and duplications, if you would have missed out, that could be picked up, sir.
Okay.
Narendran, your second question, whether academic interest, yes, it's possible. I think a few of the MTB cases, because of academic interest, we got. So probably you can discuss with some of the experts. Some of the labs, they do for poor patients or low socioeconomic patients, they do out of academic interest, they do free comprehensive genomic profile. That is possible. Probably you can connect to them actually.
Okay. And this we have seen actually, we can go back to our cases also. So some of the lung cancer cases, we have pathogenic BRCA2. We came across some 1 or 2 cases, I think, in our previous. So whether that relevance we can check, because there is a recent paper also with the relevance of BRCA in lung.
But this is clearly likely benign mutation.
Not this patient. Previously, discussions, tumor board discussions, we had, I think 2 or 3 cases we saw. I remember.
One case was basically somatic, sir, where BRCA was non-driver there, and we had one more driver mutation.
Okay. Thank you.
Thank you, sir. So basically, we'll looking for doing a comprehensive genomic panel to include for a wider vision on this case for this case. So this was a nice set of cases for a nice discussion. So I thank all the presenters and the attendees who have made this tumor board on the track. Dr. Chandra Molishwari ma'am, and the chairpersons, Dr. Seshachalam and Dr. Pushpa Singh ma'am, and all those experts have given their opinion. And thank you one and all. So see you subsequently in the next molecular tumor board. Thank you, sir.